as you are getting settled up, we can start with the next session. And I would like to invite Hester Berger, who is our medical physicist from Varian, who will be talking about craniospinal radiation therapy using Halcyon.
Thank you. Good morning, everyone. So my job is to get everyone back in the room, away from coffee. It's better than being the job of having everyone sit and want you to finish so that they can actually go to coffee. So first I want to start off with a bit of a disclaimer. I work for Varian Medical Affairs, but this is an academic talk, not a commercial talk. About a year and a half ago, we were facing a situation where the question was asked to us, some of the departments in Africa are getting Halcyon linear accelerators. Can you do good radiotherapy planning for craniospinal irradiation on a Halcyon linear accelerator, considering its inverse planning only, and most of the departments traditionally have been using 3D conformal. So this is, I can't even call it a study. It was a bit of an investigation to take a look and just see how would you approach craniospinal irradiation using the Halcyon linear acceleration. And it was done in collaboration with my friends at UCT and Groote Hospital, and also with Luca Cosi and Antonella on Varian and Radicus side. So craniospinal irradiation, as all of you know, is complex. The target is complex. It includes the brain as well as the spine. When I did the first planning, I took a plan that I was really proud of to Jeanette, and I said, look, Jeanette, I can do it with VMAT. And Jeanette looked at me and shook her head and said, okay, we need to sit down about the targets that you were actually using for this. And I said, why? I used a target that was used for 3D before, and she said, that's the problem. For craniospinal irradiation using inverse planning technique, you have to change the way that you actually do your contouring, and based on that, change the way that you do your planning. And I said, okay, but what do I include? And she said, anywhere the CSF flows. And this was a light bulb moment for me, because I had to go back and learn a little bit about where does CSF actually flow. And the one place that I had missed entirely was the optic nerves. And this would mean a recurrence for the patient. If you took the information that you had available from your 3D days, you simply took those kinds of targets and you did inverse planning on it, you would really be messing up like I did on that first plan. So there are a number of guidelines available, luckily for the people starting this transition, to say, what should I include anywhere the CSF flows? You also need to take into account that you have a target where you have to force the dose to with inverse planning. You also have critical structures that you now have to actively protect. The thing is, in the 3D world, a lot of this was done automatically because of the beam configuration. The beam geometry that was selected for 3D automatically included a lot of these targets. We know in the 3D world, we used feathering multiple plans. Any physicist in the room will know how they hated a 21 field plus plan coming to them for quality assurance. But all of this changes when you move to inverse planning techniques. We can plan prone, we can plan supine. In Groote, the tradition was changed from prone to supine because the sedation is a lot easier for the children. But when you go to the Halcyon, you've got a couple of extra things that you need to take into account. This is an inverse planning machine only with a triple F beam. The field is actually 28 by 28 centimeters, 2 primary collimators followed by a double stacked and staggered MLC. Very good in terms of transmission dose. But what it means is your field length is now 28 centimeters. So for a patient like this with a target length of more than 58 centimeters, you automatically have to use multiple isocenters. And in the case of the Halcyon, multiple isocenters unfortunately means that the system will have to deliver it in multiple plans and also offload the patient in between. But all of this is doable. So after fixing all my problems with my contouring, and Jeanette showed me how, anywhere the CSF flows, we restarted the process and we said, if you have a Halcyon in your department and you want to do inverse planning, and in my case, I wanted to do VMAT, how would I do it? So you have to use a combination of isocenters. On the Halcyon, if you have an isocenter pair within 8 centimeters, those can be delivered as a single. If you have Halcyon version 3, 10.5 centimeters apart, Halcyon version 2, 8 centimeters apart. And if this is within this configuration, it can be delivered as a single plan. This is often done for gynae patients, for example. But in a target length of 58 centimeters, we are beyond that. We know that we're in a world we're going to have multiple isocenters, multiple plans. So looking at it, we found that for most of the smaller children, you will be able to get away with a single isocenter around the brain area and isocenter pair around the spine area. Now we know in the 3D world, we always had a problem with the spinal fields of hot and cold spots. The good news is when you do it with multi-isocenters on the Eclipse for Halcyon, for example, it deals with overlap in fields not by feathering hard, as in the old configurations, by a soft feathering technique that's driven by the algorithm itself, actually making it a lot safer in terms of the delivery. But you need to know your targets and you need to know what you are protecting. Okay, so once you've done this planning, which you can do on the entire plan, for the Halcyon you would have to split this up into plans that will be delivered separately. For this patient, you can see the total plan is split up into a brain area and a spine area. And from the brain area into the spine area, you can see the dose going slowly from hot to cold, and in the other side from cold to hot. This is the automatic feathering that is applied within the Eclipse system to give you a safe junction when you load this patient between the plans in case you have 1 millimeters or 2 millimeters of inaccuracy. All of these shifts are only in the Z direction, so your patient is moving in the couch longitudinally, no shifts laterally, no shifts ant and post. And this is how you would do it. So let's look at more detail at an example. This is an example. It is from the Groote Schuur Hospital study, one of their patients that we took. It was already planned for the Varian unique. And then I took the same plan, imported it, and did a plan for the Halcyon. So there is a reference if you need it. For this patient, we were looking at 23.4 gray for the target area, but with a provision that the spine must receive more than 18 gray, so a double dose level plan. We looked at it and we found that one isocenter on the brain and a double iso pair on the spine was sufficient to get the target length. It would require 2 setups, but only moving in the Z direction. For each of these plans, when you load them on the machine, you would add imaging sequences to the plan itself. So everyone is imaged on its own so that you are sure of your positioning accuracy. This imaging is actually in many ways better than what we have with 3D, because in 3D, on an extended SSD spine fields, you really struggle sometimes to image the matches between the spine fields and the brain fields, where here we have soft feathering in your favor and also the fact that you have imaging on each of them. So the arc geometry that we finally settled on was an interesting one. For the brain, we use full arcs, but then we add what we call a supplementary field. Rotating the collimator to 90 degrees, you have the ability on the Halcyon, like you would previously block a jaw on a linear accelerator, a C-arm, here you can limit the movement of the MLCs. So the supplementary field is used to boost the dose to the brain, which is a place where I really struggled originally. So 2 full arcs, long fields that will allow for the feathering into the spine, and 1 supplementary field that allows us to boost the brain and get in between the eyes, which is one of the areas that you often miss as well. What it is called, I don't know, ask one of the doctors, but I know there's an area that I mustn't miss. For the spine fields, sorry, Jeanette. For the spine fields, we actually looked at some studies that were published in India. They've done quite a lot of work on moving to the VMAT treatments. And they've found that for the children especially, you do not have to use the full arcs and have dose enter from the anterior or around the arms. You can close the arc off to the posterior about 100 to 140 degrees. And in doing that, you get a lot of the benefits in the dose distribution, missing the lungs, missing the kidneys, and limiting the dose spill from the VMAT into the rest of the body. So for the brain, full arcs, and for the spine, these partial posterior arcs that avoids any complexities from the arms and any complexities from anterior dose. For the larger adults or young people, sometimes you would need some anterior dose on a 6XXX beam as well, but for the small children, this should be enough. We entered all the clinical goals in advance so that we can track it throughout the planning and optimization process and evaluate at the end. But everyone knows me, knows I'm not a traffic light kind of person, so the final evaluation is not on the clinical goals only, but on the actual dose distributions. And here you can see the comparison on the Halcyon on the left and the Varian unique on the right. Similar beam configurations for both, with the posterior beams for the spine area and then the full arcs for the brain. But obviously on the unique, you can rotate the collimator and get a longer field. So your actual isocenter placement is different between a Halcyon and a C-arm linear accelerator. But in terms of the absolute plans, it was possible to generate plans for both machines that is well within the clinical requirements, and we also did this for the higher dose levels to show that it can be done there as well. So just a comparison, the only difference I saw was that the Halcyon was actually slightly better on the eyes, and this may be because of the stacked and staggered MLC with very, very low transmission. So you can decrease the low dose spill even further on the Halcyon compared to the C-arms. So as said before, you split it up for the final treatments. So it's really important to understand not only as a planning exercise what you're going to do, but what happens when the patient gets to the machine. How am I going to image it? How am I going to treat it? What is the sequence that the patient will actually experience? This is published. You can go. I've got a reference there for you as well. Like I said, in India, they also did the study on more patients than just the one that we were looking at or the couple we were looking at. Similar kind of configurations that you can reference if you want to do the C-arm versus Halcyon. The one thing that you always have to remember, it's not a planning exercise. There are differences on the Halcyon between version 2 and 3 and version 4. You always have to load the patient in what they call the load zone on the Halcyon. And in versions 2 and 3, this load zone is a recommendation, but in version 4, it's hard-coded. So there's actually a limitation in terms of how far from your reference position you can move your patient in. And when I went back to the study, I realized that this patient, because we had a total shift from the user ISO to the last of the ISO centers of 30.5, it was half a centimeter further than what would load, half a centimeter. You can change that. You can change that half a centimeter, and suddenly it's executable. So know your machine, know its limitations, because on a Halcyon 2 and 3, this would execute without any problems, which it was planned on. But on Halcyon 4, when you get to the bed, your last ISO is unreachable, whereas a half centimeter change in ISO center position makes it treatable again. So in summary, I've got some reference material for you. This is not a discussion on when to use 3D or IMRT or VMAT. This is simply looking at, can it be done? What are simple approaches to do it? And if you want to do it, the best advice I can give anyone is phone a friend. Speak to someone that has done it. From a doctor's point of view, a contour point of view, knowing where the CSF flows, okay, and what that part between the two eyes is called. Okay, speak to your team and do it jointly together, and then the last thing, physicists, take it to a machine and do an end-to-end full run so that you understand that this can actually be delivered on your machine. So thank you for the invitation, and thank you.
Thank you, Hester. Now, I would like to call our very own Dr. Ewongwo, who will talk about the avatar device in pediatric population. Thank you.
Oh, that's the wrong one. Do I need to load it up? No, okay. Yeah, that's me. Hi, everyone. I'm Agnes Ewongwo, fondly known as Aggie. I am a postgraduate year 5 resident at Stanford. And today I'll be talking about our experience implementing the audiovisual assisted therapeutic ambience and radiotherapy, what we've fondly named as AVATAR, implementing it in low and middle income countries the last 2 or 3 years. I have nothing to disclose. So as we've heard with our morning session, radiation is a very important component for the curative treatment of many pediatric cancers. But it's oftentimes difficult for our pediatric patients to tolerate radiation. There's a very important need for mobilization and precision with treatment. And for younger patients, it's often hard to keep them, immobilized and to keep them in a room by themselves. There's a lot of fear, stress, and anxiety. And as a result, most of these younger patients end up getting anesthesia and sedation for their treatments, as we've heard during our morning session. Daily anesthesia is often utilized for the duration of treatment. Sometimes that can span up to 6 weeks for some of our intracranial lesions. And there are obviously, with any treatment and medication, there are long-term and short-term side effects. Some of the short-term side effects being infection, nausea, vomiting. And what we really worry about for these longer duration of anesthesia or sedation exposure are the long-term cognitive side effects and cognitive implications. Also, like issues with language and emotional reactivity for kids when they grow older. Oh, did I? Yep. So the anesthesia utilization rates currently vary, and that's due to age. So we see that in our younger patients, usually patients less than 5, anesthesia and sedation is utilized about 90% of the time. As kids get older, that slowly drops or reduces, and drops to about 50% for kids 7 to 8 years old. And for kids older than 10, it's a lot less, though not 0. I think the estimated number is about 10% use of anesthesia and sedation for kids over the age of 10. These rates are not known, but we don't know specific numbers for low and middle income countries, but they are postulated to be higher. So what is Avatar? Avatar is an audiovisual system that was developed by a brilliant physicist who loves to use a 3D printer. His name is Laurie Skinner. He worked in collaboration with Dr. Susie Henniker, who's a pediatric radiation oncologist. And they developed this kind of audiovisual system that could be placed at the head of a treatment table to play movies and audio and cartoons for kids during their radiation treatment. It includes, let's see if I can use this. Yep, I can use that, yeah. So it includes like a projector. So a projecting device, we've been using a projector since the onset or creation of this. It also has a speaker that's kind of mounted on top of the projector. It's usually attached to the table. We've changed this over time, and I'll show kind of the newer model using this single adjustable like clamp. And then there's this telescopic mount that's attached to a thin, low atomic screen. And that screen is where like the videos from the projector is projected onto the screen for the patients during treatment. This is what it looks like from a patient's perspective. This has been tested using phantoms and TLDs, and it's been shown to have negligible radiation attenuation, so overall safe to use during treatment. So this is the Avatar 2.0. This is the newer model for the people in Uganda and UCT who've seen it. This is very similar to what it looks like now. So here, everything's 3D printed. So the clamp portion, now we use a clamp that's kind of adjustable to kind of account for different width of different treatment tables. It's attached to a projector. This allows for more flexibility to adjust to different treatment setups. So you can move this up, down, and you can also move this part of it. And again, we still use that thin, low atomic screen. And then we also have incorporated an iPad or a Fire Stick and like a dock system to use with this, just making it more user-friendly for different centers. So when we created the Avatar, we used it for 3 years and then decided to, evaluate its efficacy or the improvement of our treatments with it. So a really cool resident, Katie Balazzi, who was a resident at Stanford, did a retrospective study. It was over a 6-year time period, so they did 3 years before Avatar was introduced into the clinic and 3 years after Avatar had been introduced, and did a comparison. And what we saw was that more patients treated after the introduction of Avatar were able to avoid anesthesia, and that's depicted by the table, the graph, the bar chart on the top. We also saw that there were fewer anesthesia sessions delivered over the 3-year post-Avatar period, and this resulted in a cost savings of about $500,000. Avatar also reduced treatment time per session by 38%, which, again, for a really busy clinic and a busy center is very, very helpful. So given the success with our institutional experience, Dr. Henniker and team launched a multi-institutional study. This was a study done across 10 U.S. institutions, included 63 children ages 3 to 10 years old. And again, similar findings, the use of Avatar led to 78% anesthesia avoidance, and this was compared to 49% in age match cohorts. Again, Avatar was able to not only reduce treatment time, but also lead to lower patient anxiety scores using the modified Yale, I think it's preoperative anxiety scale. And again, across all ages, let's again point this, across all ages, we saw just a gradual decline in patient-related anxiety in the waiting room and even in the treatment room, kind of from the start of treatment to the end of treatment. So what does the anesthesia workflow? I've talked about, like, it improves anxiety, helps us reduce or avoid anesthesia for our younger patients, but it also just improves, like, the treatment, not the treatment time, but like the treatment time process, like the overall duration of treatment for patients. So if a patient's gonna get anesthesia, at least in the United States, there's usually, like, clear instructions. You have to be NPO before midnight, and you have to be NPO the entire morning before your procedure. This is similar for radiation as well. So these patients are usually no food after midnight, nothing but water the morning of. There's also, before the anesthesia, you have to meet with an anesthesiologist for a pre-op visit. And there's usually, like, a prep that happens about an hour before treatment. And then the induction session happens where you get the medications and you get anesthetized. And there are usually risks, cardiovascular risk, and any type of allergy risk associated with that. It's not, there are emergencies that can happen with anesthesia and induction. And then before treatment, each morning we have to do collision checks of our machine, and then we have to set up a remote monitoring system so that the anesthesiologist who's outside of the room has access to patient vitals and patient airway. So there's quite a bit of logistics that goes into treating patients with anesthesia. And then the treatment itself is about 20 minutes. And then after that, the patients are sent to PACU, a post-op area to recover, and this is usually about an hour to 2 hours, and they're usually things like nausea, vomiting, and GI side effects related with anesthesia. And then we do this every day, again, for up to 6 weeks until that patient's done. And if they have recurrence or they have to come back, again, this workflow starts from the top, and we do it all over again. And again, like I talked about, some of the long-term cognitive effects is really what we worry about for our younger patients with long durations of anesthesia exposure. Now with Avatar, all you need to do is set up the Avatar. I say 2 minutes, but the people in Uganda, like Solomon's team and Dr. Naika who watch, it takes a little bit longer than 2 minutes when you're first starting up with it. But once you become proficient and you're pretty skilled at using it, I would say about 5 minutes of setup time. Put it on the treatment table and you just swap out the patient's setup. And then the treatment time itself is about 20 minutes, so reduces this 4-hour process to about 30 minutes to 35 minutes. Okay, so Avatar implementation Sub-Saharan Africa. So in 2022, we donated or deployed a device at Kenyatta to Kenyatta National Hospital in Nairobi, Kenya. And then after that, we also deployed one in Dr. Moya's team at Ocean Road Cancer Institute in Tanzania in Dar es Salaam. And since then, we've kind of optimized the workflow quite a bit to adjust to the needs and logistics of each center. When we started at Ocean Road, we realized that, kind of starting at simulation and introducing kids earlier rather than later was the best way to go. So this is at the Cement, and the team is kind of, doing their regular setup, and we set up the Avatar device with I think he was 6 years old. We also realized that, while the kids are in the waiting room, having some type of, audio-visual something going on is really helpful. It decreases some of their anxiety and fear with, being in a room and having the device over their face. So we also kind of gave an iPad, and this iPad is usually kept in the waiting room, and the kids get to watch cartoons while waiting, which just helps them get really excited about getting into the treatment room and continuing their videos. And then this is a patient undergoing treatment. So we have an iPad in the room, and then we have an iPad in the waiting room as well. So the team in Tanzania was very excited, and the residents wanted to do a feasibility study looking at the benefits and the efficacy of Avatar in their center. And so they launched this feasibility trial in 2023. And this was just the quick hypothesis. We were interested to see if Avatar would help reduce the need for sedation. They don't use general anesthesia, they use sedation at Ocean Road, and improve the overall rates of treatment completion. We kept the numbers low to about 10 patients just to avoid adding an extra burden on the system. And then we compared those patients with 10 patients who were treated without Avatar. And these were some of the objectives. Again, just looking at the number of fractions that were completed without Avatar, looking at overall treatment times, and then looking at, again, rates of treatment completion. Thankful to the residents at Ocean Road for sharing the data with me. So it's just a quick summary of the Avatar cohort, the 10 patients. Again, most of these patients were young, median age of about 4.5 years. Most were male. And again, the theme of Wilms continues. Most of the tumors that were treated were Wilms tumors, and the irradiated site was the whole abdomen. And what we saw was that all the patients in the Avatar cohort were able to complete their entirety of their treatment without sedation. And what we postulated was that given the ages of these patients, 70 of them would have required some form of anesthesia or sedation due to, again, patient-related anxiety. And we saw an average of 9 fractions of radiotherapy were completed or delivered without the need for sedation or anesthesia. So implementing Avatar globally, we started at Ocean Road, as I mentioned. We've also deployed a device to Romania, and they are also running a feasibility study there. We've deployed a device as of this week to Uganda, thanks to Solomon and his team, a device in New Delhi. And in New Delhi, they're using it for brachytherapy patients. So this can be used in adult patients as well, so it's not restricted to pediatric patients. And then also Kenyatta, and as of 2 days ago, we have one here at UCT, so thanks to the team. Again, with technology, there are always challenges involved. Some of the challenges are, again, it takes quite a bit of training up front to train the staff, to train the physicians, and to even train, some of the radiotherapy team members about how to set up the device and to deal with any type of glitches or issues that happen, so troubleshooting issues. There's also quite a bit of patient and parent coaching, and we talk to our team members to kind of educate parents and to encourage parents to keep educating kids while they're home or while they're outside of the treatment rooms on just what the Avatar is and what to expect when they get in the room. Again, decreases some of their anxiety and fear with having that device over their face. Again, adequate staff training. We've been doing in-person training, so when we deploy a device, we usually will send a team out there just to train the staff and kind of deal with any issues that come up. And then as I learned this week, when it works really well, and it can actually create quite a bit of distraction. So this is a 2-year-old. This was her first fraction without sedation, and this was in Uganda. And she was so excited watching My Little Pony. She started trying to touch the ponies on the screen, and this is where coaching comes into play. Thankfully, we were treating the abdomen, and we were far from the head and neck region, but just coaching patients and parents about sitting still and avoiding, any type of interaction with the device while they were being treated. But she was very, very excited and was able to get through 5 minutes of her treatment without any need for sedation. So some next steps. So we're, waiting for the write-up. We're currently analyzing the data from Ocean Road, and the team over there is going to write it up and hopefully publish it. We're waiting to, hear from Uganda about their experience, and also from Cape Town, and then just, continued collaboration across the globe. Thankful to our team, Dr. Hineker and Lori and the rest of the Avatar team, and thankful to the Catalyst Grant, the Stanford Catalyst Grant, for providing the resources and funds to not only deploy these devices, but to provide training and support for our collaborators. And thankful to all of our collaborators and UCTs at the bottom. Just imagine you see it. I did my slides before we did the training here, so yeah. Thank you, guys. That's pretty much it.
Thank you, Aggie. Next, I would like to invite Dr. Anita Mahajan on stage, please. She would talk about brain radiation therapy.
Thank you very much. And I thought this would be a good topic for us to review since there's been a lot of activity going on in the management of brain metastases. And thanks to the organizers, and I really appreciate being here. So, in the old days, and not so distant past, whole brain radiation was very easy. It was simple, single brain met, patient comes to your clinic, you do whole brain radiation, you set them up on the table, put a piece of tape over their head, and go. Occasionally, if you're fancy, you would put an eye block. So one size fits all, clinical setup, doses are the same, and very uniform. Fast forward, this is our now situation for when we see a patient with brain metastases. It's really become quite complicated. And depending on the integration of the multidisciplinary groups, you have surgical considerations, systemic therapy considerations, the patient themselves and their clinical situation, clinical trials, and ultimately, I think the patient has to be involved in the management of their own care. And so it has become really a lot more complicated. We're thinking about quality of life for our patients as well. So I did a quick search on PubMed, and this was a few months ago, so maybe these numbers are even bigger now. But within the last year, there was 467 reviews and 110 guidelines out there. So when you start looking to the literature for some guidance, it can become overwhelming very quickly about how to manage all the different types of combinations of patients that will come to see us. You know, sometimes you make your own guidelines with what you have in front of you. So the way I've approached this talk is to sort of look at the 7 different types of brain involvement that we see. Some are easy, some are harder, just to kind of think about what our options might be. So the easier ones, 1 to 3 small brain metastases. You think about, this is the way I approach it, bullet by bullet. I think of the size, the location. Can you do surgery? Yes or no? Why would you want to do surgery? Is it for mass effect, remove the tumor, or establish diagnosis? You think about the symptoms, the urgency of it, the need for steroids. For new metastases, if a patient hasn't had a prior diagnosis, then this might be relevant for establishing a diagnosis. Systemic status, if you have a small teeny-weeny metastases, is it necessary to go after it right away if you can start chemotherapy and reassess the situation in a month or 2 or 3? The pathology is less relevant here if you really want to get going on something. Is there a clinical trial? Patient preferences. I find patients, some of them like, treat it immediately. Other patients are leave me alone and we'll see how things go. So, you know, a situation like this, you have a small posterior fossa single lesion. You could watch it if the patient's reliable and you know that there's going to be subsequent care, or just proceed with radiosurgery. So if you do radiosurgery alone, local control for the lesion that's treated is very high, greater than 85 to 90%. The brain control, this is where the challenge is that we know 50% of our patients will develop subsequent brain metastases elsewhere. So what do you do for surveillance and informing the patient that they're at risk because there's going to be other cells? Toxicity, very low, less than 5%. Interfering with systemic therapy, very little. You can do this one day, continue on chemotherapy, do it between cycles, do it concurrently. And ideally, they need to get surveillance. We use MRIs, but at least some sort of surveillance to be coordinated with their systemic therapy so that you can manage the subsequent metastases when and if they occur. Technically, there are some guidelines out there about how to establish a radiosurgery program. And essentially, for small tumors, you can use any technique. So out there, you have LINAC-based treatments, gamma knife, cyber knife, and LINACs do need special modifications to really do the QA to have that precision of delivery. And you do need the expertise and resources, especially the physics support, to establish a radiosurgery program. So there's a summary of recommendations that are out there, and this was a very nice publication from last year, and it's in the PRO journal. but there's guidance about imaging, the contouring, the patient treatment and delivery, and then the dosimetry. And based on the type of technology you have, they had different guidelines for Gamma Knife versus Linac-based. So I thought this was a very nice review to establish some sort of platform. In our own practice at Mayo Clinic, when we do Gamma Knife, we don't use any PTV. It's just really the GTV itself. And it's a frame-based technique, and we feel that the immobilization is very good. For the Linac-based, I actually think it's actually 1 to 2 millimeters now. I should change the slide. So we do 1 to 2 millimeters PTV for Linac-based. So moving forward, 4 to 15 brain metastases. So there have been new data looking at the evaluation of different types of approaches for more than 3 metastases. There is a publication by Hughes where they looked at over 2,000 patients, multi-institutional, and they did notice that the outcomes do vary by the number of brain metastases. It's also affected by the type of tumor it is, so breast cancer versus other, systemic involvement, performance status. And so these are the type of things that we know intuitively that patients with a poor performance status, a large burden of systemic disease, they're not going to do as well as somebody who has brain-only failure, who has good options for systemic, and a younger person with good performance status. So when we evaluated our own practice, when you start treating 4 to 15 brain metastases with Gamma Knife, it can take a long time. Each one takes about 10 minutes to treat. And so if you multiply that by the time you have 6, that's an hour of treatment. If there's a large one, it's 15, 20 minutes. So it becomes quite burdensome. So here at Mayo Clinic, we've established a single isocenter treatment approach with Linac, where you can actually do the treatment in 20 or 25 minutes. So for patient purposes, the treatment delivery is much easier, but they do require simulation and a few days for planning. So Dr. Routman is one of our clinicians, and we looked back at what makes a patient with multiple brain metastases good or bad. And essentially, we looked at SRS 2 to 4 versus 5 metastases. And the higher risk patients really looked, it was the total volume of the tumor burden that seemed to be associated with outcome. So if you're trying to think of something to have a gestalt of what patients might do well, this might be another parameter to look at, the total volume of all of those brain mets, and understanding, well, maybe if you've got these big, huge metastases, we're not going to get good control with radiosurgery because our dose goes down, plus it's a burden of disease. Perhaps that's not the best patient for radiosurgery, and maybe we use alternative approaches. So next kind of patient group are those that have a large brain metastases. So you have 1 or 2 or 3 metastases, one of them is big. So where does surgery fit in? And here, there's been a lot of experience now, and people were quite interested in the mid-2000s about how to manage the post-op cavity. So there was a couple of studies that were done, and both of them showed that you can improve local control by doing radiosurgery to the tumor bed. If you add whole brain, there seems to be a benefit in distant brain control for sure. And of course, there's the original Patchell study showing that whole brain radiation on top of surgery improves survival. So currently, we know that removing the tumor oftentimes can help with many different issues, including possibly survival. SRS alone to the surgical bed improves local control. Whole brain radiotherapy adds to local control and brain control, but there's cognitive deficits. So these are the type of things that you may want to discuss with the patient about, do you want to live longer or come back for surveillance? We do think you need radiation, and how to sort of generate a plan for individual patients. So this is an example of a patient with a single brain metastases in the right temporal lobe. It was resected. There's a surgical cavity. Let's see if this works here. So this is the post-op cavity here. You can see there's a little bit of enhancement residual, but then that becomes our GTV. And then we have a nice little plan that delivers a very conformal dose to that area. So the planning and treatment delivery is very similar to when you treat a single brain metastasis that's intact. But there's questions that are around, and we're trying to establish some approaches nationally. Is like what is the CTV, what is the GTV in a post-op cavity? Do you cover the dural tail? How much of that post-op enhancement do you cover? Is pre-op versus post-op better? There's some trials now looking at that. BN012 is looking at pre-op versus post-op. What's the dose? Do you give a lower dose, higher dose? Should we be fractionating? So this is the other question that now comes up. Should they all be single fraction where a bigger cavity gets a low dose, or should we fractionate it and give it in 3 to 5 fractions? So these are all questions, and there are studies going on in the NRG environment looking at one versus multiple fractions and looking at pre versus post. So hopefully we'll have more answers in the next short while. So let's see, this is going to be tricky. I have a video in here. Do you think I can do it? I'm not sure. It was a cool video too. Oh, there it goes. Aha, yes, so there's the plan for a patient who had multiple brain metastases, and you'll see little areas of hot spots showing up all over the place, and then up at the very top, there's a big cavity. So in this particular patient, it was a 64-year-old patient with adenocarcinoma of the lung, and because of the size of the cavity, we ended up doing 3 fractions. We did it 3 weeks post-op, so that seems to be something also for direction, is that ideally after surgery, you should get the treatment in within a month or so. The PTV total was 19.6 cc's. The mean brain dose was 6.9 gray, and then hippocampal doses were 5 gray. So hopefully with this approach, we get good tumor control, spare neurocognitive issues, and memory issues with that plan. Oh, there you go. So that was it intact. And let's see if we can, there. So brainstem metastases are another group of patients that we sometimes find somewhat challenging because we don't want to injure the patient by overdoing it in the brainstem. Here is a nice publication summarizing results for brainstem brain metastases. Overall, SRS doses are around 11 to 18 gray, so less than that typical dose of 20 plus gray we might use elsewhere in the brain. The overall survival, 4 to 16 months, so similar to anything else. Local control was high, 80 to 90%, even in the brainstem. Toxicity was less than 10%, so again, we can treat these small lesions in the brainstem effectively. Negative predictive factors from these studies, a bigger size, which makes sense, midbrain versus pons, patients with symptoms, and prior whole brain radiation. So those are the type of things that would suggest the patient may have a worse outcome. Better outcomes if they have smaller lesions and if they're receiving systemic therapy, which also suggests a better performance status. On a practical level, when we're doing a brainstem lesion, we'll limit the brainstem dose to 12 gray to less than 1 cc. So now, does histology matter? If you look into the literature, there's different guidelines for brain metastases, for renal cancer, breast cancer, melanoma, non-small cell lung cancer, even ovarian cancer. So here's some examples of the different algorithms that are out there for management of breast cancer patients with brain metastases versus lung cancer. I think a lot of them are very pragmatic, and it makes sense with the systemic therapies, the burden of disease, the radiosensitivity. But again, if you really want to drill down, these guidelines are out there and available for management of specific cases. Small cell lung cancer, also there's been a changing paradigm about what to do. Historically, we used to just give everybody whole brain. We used to give elective cranial irradiation if you have good management of your primary site. So these days, we do still separate into extensive stage and where the primary is treated versus those where patients have actual brain metastases. So that's one way of categorizing them. And there, we've even incorporated radiosurgery if a patient has 1 or 2 or 3 metastases for small cell lung cancer, knowing that they're at higher risk for developing other metastases. PCI has become less and less common, but it's still out there, that if you have a patient who's had a good response elsewhere giving prophylactic cranial radiation, it's out there, but we involved the patient in that discussion to understand what their goals are and what they'll accept. There's hippocampal avoidance prophylactic cranial irradiation to try and spare neurocognition, and there's even tumor treating fields. Now, I don't know if that's available here in Africa or not, but these are the electrical fields that people place on their heads to try and reduce tumor progression. Next group, more than 15 METs, what do you do? We can keep on going here. And there is data from Japan, at least, where they've treated up to 50 metastases. After a point, you just wonder whether we should just go to whole brain radiation. I think whole brain radiation should be discussed with these patients. Some patients are very reluctant to accept that. You can offer hippocampal sparing. You can offer memantine, which is a medication, or you can even offer supportive care in situations. The Quartz trial was published looking at 20 gray and 5 fractions whole brain radiation versus supportive care for over 500 patients with lung cancer, and essentially overall survival was the same. So this would be the discussion points to think about for your individual patients. 20 gray and 5 is not our standard dose, but I know there's groups that do that, and it seems to be similar to 30 gray and 10 as far as tumor outcomes, but I do think there would be higher chances of neurocognitive issues. So whole brain radiation, if you do think about it, there's ways to think about toxicity reduction. Automatically, we consider hippocampal avoidance. It does require IMRT. It does require contouring. It does require some sort of delay in treatment if you have the planning. So for the patient, it might take more time. For the team, it's more expensive. Technology, you need to have the dosimetry and everything. Memantine is a medication that's used for patients with Alzheimer's disease. And there's a nice study published that showed that if you add memantine to the radiation, continue it for 6 months, there's an improvement in neurocognitive outcomes. So we think of this for many of our patients now, essentially all of them, if we remember. Sometimes I think I need to take memantine. but it is something that is out there. It's easy to give, it's well tolerated, and patients do benefit from it. So this was the study from NRG looking at whole brain plus memantine plus or minus hippocampal avoidance. And it did show that if you do all 3, there is a benefit in these neurocognitive tests that were done in over 500 patients. So with hippocampal avoidance, whole brain radiation, and memantine, cognitive failure was prevented. It reduced symptom burden, so patients had a better quality of life, and fewer cognitive symptoms. So there was no difference in overall survival, progression-free survival, or toxicities. So it's a safe process if that's available to you. We have lots of current protocols, and it's very interesting. So NRG BN009, looking at salvage hippocampal avoidance, whole brain radiotherapy, and memantine versus radiosurgery. So essentially, patients who have new brain metastases, whether we should do subsequent SRS or just jump to whole brain with the cognitive sparing. There's SRS versus whole brain hippocampal sparing plus memantine. There is hippocampal avoidance versus SRS for 5 to 20 METs. This is being done in Boston. Interesting, newer develops is more tissue sparing. So both at Mass General and at UCSD, they're trying to do more and more white matter sparing and trying to spare eloquent brain white matter, where brain metastases usually don't set up shop. They're more at the gray-white junctions. So we'll see how that goes, and we're going to get even more complicated. Last topic, LMD, leptomeningeal dissemination, and there was a disruptive paper that was published out of Sloan Kettering last year or the year before, and essentially They gave 30 gray and 10 fractions proton craniospinal versus involved field for patients with LMD from non-small cell lung cancer or breast cancer, and they showed a survival benefit when you do proton CSI compared to just treating the symptomatic areas. It's not a really fair comparison, but I do think this is the one of the few trials that's actually shown a survival benefit. I always question how would patients do with X-ray based craniospinal, and so in our institution we've been looking at our own practice. This has sparked a lot of activity for management of leptomeningeal disease and referrals to the radiation departments, and those with protons, we've been sort of like at a loss of how to really incorporate this. Remember, this is only for breast cancer and lung cancer. There is an NRG study being developed, and so that will have a larger cohort and more data. Progression after whole brain. If there is whole brain radiation, you have a lot of options. You know, hospice, treat the symptomatic sites, repeat whole brain. There's this pulse dose reduced radiotherapy, tumor treating fields, or others. So when I think about a patient, this looks very, very complicated, but essentially I look at the patient, look at their performance status, think of the size, location of the tumors, look at their systemic disease. Are the oncologists going to actually treat these patients? Are they going to hospice? Is surgery needed? And is it single or multiple? And then breaking that down, I sort of come up with kind of logical options for these patients. And conclusions, so we've really adopted an individualized approach to the management of these patients. I think of all my radiotherapy options. It is multidisciplinary now. It's not just us. We have to talk to the oncologists and the surgeons. Patients need to understand they have to have surveillance and follow-up because no matter what, if there's new metastases, these need to be evaluated. Patients need to be involved, and then we do consider trials when they're available. And with that, thank you.
Thank you, Dr. Mahajan. Now I would like to invite on stage Dr. Tracy Irura, who will talk about her CyberKnife experience.
Oh, wow. Thank you very much. It's always a pleasure to be here at GHOS. I will talk about the CyberKnife experience. Thank you, Prof, for bringing in brain metastasis. This is what we are mainly treating. My name is Tracy Irura. I work at KU Referral Hospital in Nairobi, Kenya. I have no disclosures. This is what I'll really talk about, just the overview of the machine itself, some of the experiences we have at KU, and some of the data we have so far. So the CyberKnife is a robotic radiosurgery system. It's the only non-invasive robotic system treating tumors anywhere in the body. So we have SRS and SBRT. We have continual imaging throughout the treatment. I think this is the most fancy thing about the CyberKnife treatment. And then the high-dose radiation and pinpoint precision, we always advertise it as sub-millimeter accuracy. So the history of CyberKnife, of course, it was developed by a neurosurgeon, not a radiation oncologist, but we were the ones using it. So the neurosurgeon actually had gone to Germany, and there was a car assembly point. And he saw this robot actually assembling the cars, and he thought, this robot can do more. So it came into clinical action in 1990. So it has been there for a while, but of course for us, Africa, this is completely new development. In 2002 is when he thought it can do more than just the brain. So we started doing SBRT in 2002. It can treat a lot of other extracranial structures. And then, of course, because of the precision, and it can also do coplanar and no coplanar kind of treatments. And the main thing is, of course, the precision of SBRT and SRS. So this is how it has developed over the years. What we have now is, we have the latest now. This is what we have at the institution. It's an M6 S7 series of the CyberKnife. So this is exactly what we do have. We got it about a year ago. And the main components, I think the pointer, oh, perfect. So the main components that we have are the robotic arm. So most of the people just say, oh, it's a robot. So the robotic arm that holds the linear accelerator, I think this is quite fancy. We have the collimator. So we do have 3 kinds of collimators. We have the fixed collimation. We don't use a lot of the fixed collimation at our institution because of treatment time. We have the iris system, and we also have the MLCs. The other thing is the 2 X-ray units, camera A, camera B, we call them, at 45 degrees. They're attached to the ceiling board here, and then we have the image detector at the bottom. This is the standard patient treatment couch. There are some robotic ones, but we have a standard one. So the main thing about the robot is that it has 6 degrees of freedom, and because of this, it has very many axes, have X, Y, Z, and then we also have P, R, and W axis. And because of that, we have what we call nodes that the robot is able to, it's a pathway that the robot is able to take, and we have up to 100 nodes, and each node has 12 possible angles that the robot can take. Therefore, we have about 1,200 beams that we can use to treat our patients. So what are the capabilities? The main one is the robotic system. So it can do both non-coplanar, sub-millimeter accuracy, and a wide range of motion. And then we have the intrafraction imaging. We do imaging every 30 seconds during treatment. So our treatment times are quite long, 20 to 30 minutes. But we do 30 seconds of imaging, and we align the robot as need be. And then it has true dynamic tracking and correction. And of course, the main important thing is that it can minimize the dose to the healthy tissue and maximize the dose to your treatment site. So these are the 2 isocentric and non-isocentric kind of treatments it can do. Clinical applications, intracranial radiosurgery. This is the most common that we use now. We've just had it for about a year, so we're not able to do SBRT as yet. So these are some of the challenges that we hope the GHOS experts will help us with. But there is spine, lung, liver, and prostatic. We do fractionated radiosurgery. We do it 5 fractions, either 25 or 30 gray. And of course, the clinical experience has been proven. We have quite a number of papers that are being published all the time. The advantages of the CyberKnife system is the excellent long-term cancer control because, of course, you avoid the critical organs. The CyberKnife is a walk-in, walk-out. We always tell patients, come in the morning, by 11, you're already home. Fewer treatments, so for prostatic, it will be a game changer with the hypofractionation. And then the side effects are minimal, especially for patients with brain metastasis who do not want to lose cognitive function with whole brain. CyberKnife is definitely an option, depending on how many lesions they have. So the main differences is mainly the targeting. It's sub-millimeter accuracy, treatment duration, 5 treatments. Procedure type, we don't have any invasive procedure that we do, but we do give them pre-meds, mainly steroids for SRS. Patient comfort, patient can move, but we do give them a 5-point mask. Side effects, they are minimal. Convenience is that there is a shorter duration time, and versatility is that we can also do SBRT. The tracking algorithms that the CyberKnife uses, so as I said, it can really treat anywhere within the body, but mainly for the skull, this is for SRS, we use skull tracking. And for respiration, we normally say that the machine moves as the patient respires, so we don't have to do anything like gating or breath holds, especially when you're treating tumors within the lung. Lung metastasis is something we see very common, but it has 6 different algorithms. Accuracy, I know for especially EBRT, we've been using mechanical accuracy that we must reproduce all the time we are treating the patient. But for CyberKnife, actually, if the patient moves and we are taking the imaging through and through, we're able to see, and we can actually enter the room and change the couch as need be, depending on what offsets we have. This is how we advertise the CyberKnife in KU. So these are the flyers that we give patients, just telling them what the unique features of this machine are and some of the conditions that are treated. Of course, being African, everyone wants everything treated. So we always tell patients, unfortunately, it can't do craniospinal irradiation. They don't understand that. This is where I work. I did come with a few of my colleagues also. This is the KU Referral Hospital. It's quite vast. But the oncology program is actually our flagship program. So the hospital was set up in 2019. We have about 600 beds. And oncology is the most, maybe most interesting, I would say, program that we have. And it is a government institution fully funded by the government and taxpayers' money. So for radiotherapy at KU, we have a linear accelerator, the only one that we have that is, of course, overburdened, like most African countries. And then we have the CyberKnife. So you can imagine, from this to the CyberKnife, we do have 3D brachytherapy also. I would like to talk a bit about our experience at KU. So we've had this machine for about a year. It's the first one in sub-Saharan Africa. We have treated about 90 patients since we started in 2023 September. Many of our patients, we are doing 5 fractions. We are not yet very confident to do trigeminal neuralgia, that we just do very high doses in 1 fraction. About 40 minutes per session is what we do. We do have radiation oncologists who are trained RTTs and physicists who are actually trained by Accuray themselves. We MDT all our patients with international faculty. Also, it helps with our skills. Our workflow, so of course the oncologist will see the patient and prescribe the treatment. We have a CyberKnife manager who books in the patients. Then the rad-onc will review the cases and qualify them for treatment. Then we have what we call the intent forms. So our CyberKnife is fully funded by the government. The treatments are absolutely free to our patients. We do the CK simulation, we do MR with contrast, and then we do planning, quality assurance, we treat the patient, and review the patients every week after that. Patient setup, as I said, we use the thermoplastic masks, 5-point masks. For lung synchrony, we use the vests, though we are not yet here. This is what our treatment planning system looks like. Actually, this was patient number 1 with a CP angled tumor, and this is exactly what the TPS looks like. CK delivery on our machine. So you can see this patient had some offsets. We do give them, with skull tracking, our offsets are very minimal. So, but if the offset is more than a certain millimeter, we go into the room, stop the treatment, and adjust accordingly. So I'll bring you some of the data we have so far. We have treated 90 patients. Most of them are female for obvious reasons. Female have better health-seeking behavior, but also we treat a lot of meningiomas. The age, most of our patients are middle age, about 41 to 60 years, about 45% of the patients. We don't do any pediatric patients as per now, mainly because we don't have Aggie's audiovisual system yet. Our referral pathways, most of our patients will come from the neurosurgeon because most of them are actually not, as I'll show you, most of the diagnosis is, of course, brain metastasis, but we do have other non-cancerous. So the diagnosis we have, the number 1 is brain metastasis, mainly because of oncology patients. But meningiomas, WHO, grade 1 and grade 2 are quite a number. And some of the meningiomas we see are quite large, but this is closely following. Then we have some pituitary microadenomas that we do treat. Spine metastasis has been giving us a bit of a challenge, but we are treating those also. Low-grade gliomas, of course not GBMs, and schwannomas, a few of them. They respond quite well. So this is just a pictogram of the diagnosis that we have. So what's the future for us? I think CK will be the future, mainly because of AI. So SRS and SBRT is the future in RadOnc. More people are moving from EBRT and whole brain kind of radiation. For us, our main challenge has been fiducial marker insertion, mainly because we do not have that many IRs in our country, and this is mainly an IR procedure. And the patients also have to pay for the gold seeds, which is not cheap. The other thing that we've seen as a challenge is, of course, onboarding more people, making more people aware of this, and just giving more people training. So we are hoping and asking GHOS to kindly give us some more personnel and to come into Nairobi next time so that we can train. So this is our cyberknife. We work as a team always. These are some of our RTTs, and at least our room has some life. We've put some one life there, and this is what Nairobi is all about. Thank you very much. Thank you, GHOS, for your platform. Really do appreciate.
Thank you, Dr. Irura. Now I would like to call on stage Nanette Joubert, who will talk about medical imaging in radiation oncology.
Thank you very much. Okay, my only disclaimer at this stage is that I'm a medical physicist, so I expect a lot of different comments here, much like Hester's. We might not have all the correct clinical words, but we're there with the technical stuff. Just also to say, some of these slides are also taken from other presentations from my colleagues. You'll see that referenced in the slides, so I don't want to spend too much time on that. But we are also in a department with a lot of Varian equipment. I'm not marketing it, so if you see all the pictures, it's just that was at my disposal. So I'll be talking to you about imaging for radiotherapy. And when I started to put this talk together, I realized that this is a very big and wide subject. So I've decided to just give you a few highlights and summary of the whole radiotherapy process and where imaging is used and some examples of that. So I'll focus very quickly on diagnostic imaging because, of course, that would be the start of radiotherapy. Then imaging for planning, imaging for setup verification in the treatment process. And then, because I'm a medical physicist, of course, I'll have to speak about quality assurance. So in the background on the slide, you can see the old main building of Groote Hospital. That is where I'm situated, and also then at the University of Cape Town. So in the diagnosis of cancer, there's a lot of imaging that is used. CAT scans, MRI scans, ultrasound, PET-CT, SPECT-CT, and even just by bathing children, there's also diagnosis in there which is not necessarily imaging, but without imaging, probably we won't be able to diagnose and continue with the radiotherapy process. Which brings us then to the radiotherapy department. So in the radiotherapy process, the big aim of radiotherapy is then to give the right dose, but also to the right place. And in one of the first talks today from Dr. Berger, she also mentioned that. So the right dose is always a concern in terms of we have to do the dose calculations and we have to ensure that the monitor units are calculated correctly if we use Linux. But very importantly, if we don't put that dose in the right place in the patient, our therapy actually has no use. So that is where imaging becomes so important. The other very important thing to remember is that a human patient walks into the radiotherapy department. But after that, at the start of the radiotherapy process, as soon as we image the patient, that patient becomes a virtual patient. Throughout the entire planning process, all the algorithms that you have in your planning system, all the quality assurance tests that you do are done on a virtual patient or on a phantom. And it's only when the real human patient is placed on the treatment couch for radiotherapy again that we are back to the real patient. So we need to ensure that that patient that walks into the department is imaged and then digitized correctly in order to deliver the treatment correctly. So if we look at image acquisition specifically for radiotherapy treatment planning, there's a few considerations that we need to remember for oncology CT scanners. So I'm not going to go into all the detail, but just as a reminder then, we prefer a large bore, specifically to be able to fit the patient with all of the immobilization equipment inside. For our visitors from the US and Europe, in Africa, we have, with all due respect, big mamas, and we have to be able to fit those patients with our immobilization equipment in the CTs. So we also have to look at the CT to ED curve, the electron densities, or then what we use in the planning system to be able to calculate the dose and the monitor units needed. We need to ensure that the lasers are accurate, because that is what we ultimately use to set up the patient initially on the CT, and the flat tabletop or couch top, because that is the same that we will use in the, on the treatment couch. So just to remember then that the therapy scan is not equal to diagnostic scan, and that is why we have these considerations. So there's an example of a patient on a wing board, much the same as a breastboard setup. And this picture was taken through the bore of a SPECT CT in the nuclear medicine department, which does not have a big bore. And if you look at the picture on the right-hand side, you can see parts of the anatomy cut off because of the bore size. So although the patient physically moved or just fit in the bore, the anatomy is lost if the bore size is not large enough. Then dealing with motion during imaging, there was some mention already about gated imaging, and then of course deep inspiration, breath hold. So these are all techniques that we can implement to make sure that we digitize the patient correctly and have the information in terms of the movement of the anatomy of the patient to be able to plan accurately. Then still in terms of imaging for radiotherapy planning, immobilization equipment is imaged with the patient. So we need to ensure that the immobilization equipment can be used for radiotherapy. And why I say that is on some of our scans, on specifically this was for a cradiospinal patient, we noticed that there were high density inserts in the immobilization equipment in the board below the patient. So you can see these two white, high density inserts in the board. And we started to investigate that. And what you can actually see in the dose distribution, that there was indeed a change in dosimetric effect because of these high density inserts. So what I want to bring home about this is that you have to probably do QA on your mobilization devices before scanning them the first time in the patients. So we ended up not using this board anymore, changed it, but if we want to have a good dose distribution, you don't want the mobilization equipment to change that. So there's just a reference that you could also look at, done with one of my previous colleagues that specifically looked at the dosimetric effects of couch tops and other immobilization devices. So if we then have this image set acquired from the patient, we then look at the planning process. So this is just a reminder of where radiotherapy came from. So in the beginning, you probably didn't need as much imaging. The radiation beam was directed at the outside of the patient and then formed or the beam shaped then just to a certain size. When the CT scanner was added, and I feel I have to mention here that Alan Cormack was a UCT trained physicist and South African born, With the CT then, we were able to actually see the inside of the patient, and we can use that information to more accurately calculate and predict the dose to the patient's anatomy. But if we move even further, with the move from 2D to 3D radiotherapy, we could then use that CT information to actually shape the dose more to conform to the shape of the PTV that we wanted. So as you can see, imaging becomes more and more important. Even more so if we look at IMRT and VMAT, where we want to really modulate the dose to the shape of those targets. So in IMRT and VMAT, as a reminder, we need the contours of all the PTVs and all of the organs at risk that you want to use in the optimizer and where you want to evaluate the dose to. So without good imaging, you cannot do good contouring, and without good contouring, you don't have the volumes to put into the optimizer, and you cannot evaluate the dose through dose volume histograms. Then in terms of planning, what can also aid us is the fusion with different image modalities like MRI, PET, even SPECT. So because MRIs and PET CTs are probably done on more diagnostic equipment, it might be needed to do deformable registration because the patients are not in the same position as they would be for a treatment radiotherapy or for a treatment scan. So software that can do deformable registration is very useful. Then at Groote Schuur, we were fortunate enough to, at last, get our own PET CT in 2022. We have still staff constraints, so at the moment we're just doing diagnostic PET CTs, but with the tender process, we actually incorporated the immobilization devices and a flat couch top with that PET CT. So we hope to then include this into our radiotherapy planning process when we have the staff to do that. So that brings me to imaging for setup verification. So after the planning process, when our real patient now gets on the treatment bed, there's a lot of different options in terms of imaging that's also available to make sure the patient is in the correct position. So we can have 2D imaging where we compare 2D MV images to the DRR from the planning system, or even 2D KV images. And then, of course, we have MV and KV cone beam CTs available on some of the equipment that can be used to compare the imaging setup with the planning CT. So there's an example that we created on our VERT system, thank you, Andy, of an MV images compared to the DRR on the planning system, and some examples of cone beam CTs. So if you get these CTs in normal KV CTs for planning and diagnosis, we get some beam hardening effects because of metal or high density inserts like hip replacements, for example. And these can be made less on cone beam CT with the correct software or applications. So it becomes a bit less obvious with the MV cone beam CTs because of the penetration of the beam. But also if you have KV cone beam CT with iterative reconstruction methods, that can also be made less, and the image quality is then quite good on the cone beam CT. There's just another example of the comparison or the overlay of the cone beam CT with the KV planning CT that you can use to see where the anatomy is and if the patient is in the correct position. Then, of course, a very important other use for imaging during the radiotherapy process is monitoring of treatment. So if patients lost weight, we can re-image patients and look at the influence of that on the dose of the patient. Okay. Then, of course, brachytherapy, and I'm going to split this into high dose rate and low dose rate. I can see Jeanette smiling at me because I just love brachy. I have to show this to you. So recently, but this is now more than a year ago, we were able to do our first CT for brachytherapy. Our brachy unit was in another location in the hospital, and we didn't have access to CT until we could move the brachy into our main radiotherapy department. So you can see all of these exciting faces. And then that's our first actual CT scan of the patient with the Fletcher applicator inserted, and on the bottom right then with the dose on that CT planned. Some of our patients, or probably half, are still treated with 2D brachytherapy, but it's been a great advancement for us to be able to have the CT and see where the actual organs are and what the doses are to our organs at risk. This is where we hope to move to, and of course we need imaging for this, is optimized brachytherapy, where we optimize the dose to the actual shape of the PTV, and then the next step would then be interstitial needles to further optimize this. Then for low dose rate brachytherapy, we're involved in retinoblastoma as well as prostate treatments. And this is an example of 2D images that we still did on our simulator of iodine-125 seeds implanted for retinoblastoma treatment. This is specifically for pediatric patients. This also advanced to CT imaging. And we did not have the avatar system at this stage, which you can see, so we had to be creative and give the patients candy to let them lie still for a 5-minute CT scan, which is also now seen in the CT. And then for prostate brachytherapy, ultrasound is very useful, where they do a transrectal ultrasound. For those of you who are involved in there, you would know. There you can see the needles inserted into the prostate, and also with a dose overlay. Then in terms of quality assurance, a lot of phantoms that we can use to test image quality, but Spider-Man is there to also remind us that with great power comes great responsibility. If we have the power to see where patients are, and if we can image them, we have the responsibility to do this well. It's no use we have cone beam CTs on our Linux, but we don't look at how the patients actually, how the setup compares to the cone beam CT. So we need to apply our minds to the data that we have available. So we do not only look at the image quality when we do quality assurance, but of course also at the positioning accuracy and how accurately our hardware and software can position patients in the correct treatment setup. And then to take it a bit further, on the Halcyon, for example, we have to use the imaging that is available to help us to do quality assurance on other parts of the LINAC. So for example, on Halcyon, we have to use the imaging to check that our setup is at the correct SSD to do dose measurements, for example. And that is it from my side. Reminder, that is the International Day of Medical Physics this coming Thursday. And thank you.
Thank you, Nanette. Next up, we're going to have Dr. Brandon Fisher. He is one of the co-founders for Radiating Hope.
All right, well, it's good to be here today, and we've had a wonderful morning, and I'm the last speaker before lunch, and I have like 32 slides, so unfortunately it might go really long. So, just kidding. I'll keep on time. She said she's going to stand. So I just wanted to give some background about Radiating Hope. We're at a Radiating Hope conference, and lots of people ask me, well, how did Radiating Hope even come about? So I'm just going to give some background. It's like a little journey before lunch down memory lane. And so first off, I'm Brandon Fisher. I'm from Utah. It's way out in the west of the United States. And I've always been involved in radiation oncology, and I did a residency in it. And at some point, I wanted to do some medical missions in radiation oncology. And at first, I couldn't find any. I had this poster up in my office. It's from Life magazine, and it basically says, "Oh, we have a fresh new hope on cancer." So that's kind of the title of this Life magazine article. and it's printed in 1958. And it's one of the first linear accelerators, and it was going to be amazing, and all of a sudden we're going to treat cancer better. And then I kind of learned what's happening in the rest of the world. 85% of the world doesn't really have access to these linear accelerators. And so for me, it was like, well, was that a fresh hope? And when did that translate into being a fresh hope? Not in the 60s, not in the 70s, not in the 80s, and now we're 2024, and it's maybe starting. So during our residency, we were under the tutelage of this professor, Luther Brady. He was 85 at the time, worked 5 days a week, loved radiation oncology, and we told him we wanted to go on this medical mission, and we looked and didn't find any medical missions in radiation oncology, and he said, you know what you need to do? Start a nonprofit, do medical missions, send radiation machines, get access to care, do trainings, do all you can, talk about it. It makes a big difference too. And so we started the Radiating Hope under the Luther Brady Research Institute. And he got us going, helped us get the initial funds to pay for the nonprofit, and then eventually Radiating Hope was born. And during our research year, we looked at why there was no medical missions in radiation oncology. Kind of ignorantly, we thought, well, maybe Africa and South America or some of these other countries don't have to deal with cancer. Maybe they have other things on their mind, other things that are more pressing. And so we got access to the IAEA and some of their directories of radiation oncology and found that cancer was a huge cause of death in these developing countries, and that really having access to care really didn't exist. And so this was Radiating Hope happened in 14 years ago. So imagine the state of things 14 years ago. These are some quick facts we learned, that 7 out of 10 cancer deaths globally were occurring in developing countries, and it was a leading cause of death. And that developing countries made up 85% of the world's population, but only had a third of the access to radiation. And this was a picture we took in Senegal of their machine, old cobalt machine. I'd only seen one cobalt machine prior to that. In Philadelphia, they had one as like an antique. You could go look at it. So in 2012, when Radiating Hope started, this was what we found from the IAEA getting into their directory of radiation oncology, and then we published it in the Red Journal. And we found Rwanda at that time had no machines, Uganda one machine for 33 million, Tanzania just had one machine at the time for 14 million, and so on. And one thing we wanted to do, so this next little part's a little video, is we went out to Tanzania, and we had a gentleman with us named Charlie Whitmack. He was just a world adventurer. And we asked him to follow some patients, and he tracked some patients from the clinic to their house and back to the clinic, and let's see, this place. Okay, so this was his journey with these patients. And he followed about 5 different patients total. These are 2 brothers, and this is them playing in their village. And that's the 2 brothers that one of them has cancer, and the other is supporting him. And the first is the immense journey just to get to the cancer center. As we had talked earlier today, sometimes people have to travel long distances to get care. And this gentleman, Siddiqui, had to travel probably about an hour and a half in buses, local buses, and he got to one of the cancer centers. Most of this video is done out of Moshi, so and imagine, I didn't get a lot of the clinical background, but just looking at him, he probably has a Burkitt's lymphoma and probably could have been treated with radiation and probably could have had a great outcome. At that time, they had no radiation therapy in this area, and he got some systemic therapy and later passed away from the cancer, treatable cancer. So, which made us want to start Radiating Hope to some degree. But one important thing is, so this quote I really like from the WHO, and it says, cancer is basically a complex group of diseases, or a complex group of diseases like cancer must be tackled by multiple fronts and by multiple partners. And so Radiating Hope, we didn't think we were going to solve all the world's problems, but we did want to talk about things and hopefully stimulate other things. We've had medical missions where the person left and was like, I don't really want to work with Radiating Hope because it's so hard to get radiation equipment in, but I'm going to start a cancer screening program for cervical cancer. And then that will take off, or some other little project. And so these are just different organizations working with cancer care globally. Of course, the Access to Care in Cape Town is amazing and does amazing things. We have other groups, ICEC doing great work. But most important to the list of people there is you, and just being a cancer doctor and being involved in cancer therapy and being out there in the front lines and caring about your patients and trying to make a difference is really the biggest thing here. So really the biggest part of that is you. And this was a picture we took from Kilimanjaro during one of those first years when we were out working there. And so sometimes on the side, I like to climb things. And while I'm here, one of the things I'm going to do is I'm going to climb Table Mountain. I'm going to go right up the face. I'll have ropes. But I've done that for a long, long time, climbing things in like Aconcagua in Argentina, called Mayo in Peru. We climbed Cotopaxi in Ecuador and Sajama in Bolivia. And I just love to climb things. And George Mallory was one of the first climbers to probably make it to the top of Everest, but he passed away. And they always asked, why do you climb? And they said, because it's there. And so it's kind of like, well, it doesn't have a great purpose. I get some personal satisfaction and growth. I learned to suffer and kind of push through things that are hard. But overall, there's not a great purpose there other than it is there. But this Far Side joke I liked, and they said, because it's not there. And that's kind of, it makes sense. Why would we do cancer care in developing countries? Because it's not there, and it's a big gap that we can fill, and we can make an impact. I like this article. So about the time Radiating Hope started, this article came out. At the time, we did this literature search 14 years ago, and there was maybe 11 articles about developing countries. And then 2 years later, this article came out. And since then, we've seen so many wonderful articles in global outreach with radiation in particular. But one thing I liked about this article is they said, well, radiation is such a complex thing. There's so many different moving parts, electricity, commissioning, that it's just not possible to do. And this article said, you know what, there's nothing further from the truth. Radiation is something we can do. We can implement it. We've gone to countries like Nepal. Dr. Subas talked last year or the year before at this conference, and he has a diesel generator that keeps his machines going even when there's power outages. And there's just ways to make things happen. And so they basically came up with this formula, how to save 26.9 million life years in low middle income countries between 2015 and 2035. I'd be real curious that now that it's been 12 years since it's published, how much impact we've made on their little formula. But I think we're making an impact. And so that's kind of how Radiating Hope all came about. And one thing we wanted to figure out is, well, how do we pay for these things? How do we get machines into developing countries? How do we get people here? How do we mobilize things? And so we came up with some projects. One of our first projects was the Senegal project. And this was about the time RadiatingHope was starting, I went to every conference. I would try to get a booth. I would go talk to doctors, and I'd just get shut down left and right. But I'm a bit of a dreamer, and I figured out, it's going to happen. And so we needed a project. And so we got a donated brachytherapy machine, and we had a physicist who married a girl from Senegal, and he wanted to get the machine into that country. They had a linear accelerator. They had a cobalt machine, and he wanted them to treat with a curative intent the cervical cancers in that area, and so we needed to get in a brachytherapy machine. So that time, that's their cobalt machine and the radiation therapy. The center had 2 radiation oncologists. They were amazing. They had 3 physicists, 3 radiation therapists, but no brachytherapy machine. And this was their waiting room there, and they had 40% of their cases. As you can see, they're almost all females there. 40% were all cervical cancer. But they didn't treat them for curatively. They treated them for palliative intent. And this was our team that first time. We had Dr. Ink, who's here, come with us, and he did some training, hands-on training, which within an hour they knew how to do it. And that's the machine in the box in the crate still at that time. And then we published our experience in Red Journal about what it was like to get a machine into Senegal, and it was a pretty scary time. That machine we went into debt a lot for, and we thought, I hope we can scrape out of this. It was more debt than I'd ever seen in my bank account, and even after paying med school and all that. And we just didn't know if it was going to happen, and we didn't know how we were going to dig out of that, and we put a lot of thought into the project, and I think it really just went from there. After that project, we saw lots of other groups start. We saw a lot of people start to believe in us, and it started to make an impact. And so then we tried to figure out other ways to get these things paid for, and we came up with a prayer flag project. So a lot of our countries we go to, we have projects like Tanzania, we climb Kilimanjaro. In Nepal, we climb to Everest Base Camp. We have a project where we go to Machu Picchu in Peru. And we take these little flags with us in honor of cancer patients, and cancer patients where we treat, or cancer patients anywhere globally. And people who climb with us become super advocates, and they go out and say, hey, did you know people are dying in developing countries of cancer, and we can stop that, or at least try to help get better outcomes, and they'll get pledges. For example, our Nepal project, we had 3 machines we were going to send to them, but they were used, and Nepal had this government statement that they could only accept brand new radiation machines. And so we had to get rid of those machines and figure out how we are going to buy them a brand new one. Luckily, being a nonprofit, some of the manufacturers can give us big discounts, and I won't tell you how big a discount they gave us, but it was big. But then we still had to figure out how to pay for it, and we trekked up to Everest Base Camp, and over about a 3-year period, we'd raised enough to pay, just with climbers, to pay for the machine, and just climbers going out and asking for $20 here or there. And it paid for that machine. They got it up and running, and about 6 months or so ago, I got a picture from Dr. Subas there, and it was a birthday cake, and it said 2,000 on it, and it was their 2,000th patients that they treated on that machine. So it was yeah. Well, thanks. But these are the prayer flags. One of our treks to Everest Base Camp, we had over 2,000 that we put up there at the base camp. And I'll skip this video just so we get closer to lunch. But one thing, so this is a climb I did in the Alps. And the statement above it is fish in the sky. And fish in the sky has been my life motto for years. Like I said, I'm a little bit of a dreamer, and sometimes I do things that are different. And for a year or so, I lived out of a Volkswagen bus and just traveled around. And when I was living in that bus, I was reading this book, Walden Pond, by Henry Thoreau, and came up to this passage, and it had to do with fish in the sky. So I'll just say the passage. It's kind of confusing, then I'll explain it a little bit. So he said, "Time is the stream I go fishing in. I drink from it. And as I drink, I see its sandy bottoms and detect how shallow it is. Its thin current slides away, but eternity remains. I would drink deeper, fish in the sky, whose bottoms are pebbly with stars." And so what he's saying is Henry Thoreau slipped away from society for 2 years, lived by a pond, and just wrote about his experience. During that experience, he would look into the pond, and he would see that it was kind of shallow. He would look down, he'd see that it had a depth to it, and the depth was short. And then he said how different our perspective would be if we could just flip it. And we start to see stars as our pebbly bottoms, and then at that moment that we see so deep, we begin to see fish in the sky. And that's kind of what we're working with here. We're working with people that are seeing fish in the sky, that see a greater depth to the world. I heard a story about from Jay, Dr. Shao, saying that across the street from them opened a proton center that just treats prostates. And I thought, oh, that's a shallow moment. Like, you're only seeing a couple feet deep, and you're only making an impact in your little teeny world. But then we see people that are making a big impact and come into these conferences and want to change things in their country. And that, for me, is a huge moment. You're seeing fish in the sky. And so everybody here, people I really admire, you're fish in the sky type people. You see a greater depth to the world, and you try to make a difference. And it's GHOS. My first meeting was so small, but now it's grown to now 90-some people here today. We do a climb, but anywhere you have, like if you're in Nairobi and you know of something amazing there, we could organize an adventure there and create super advocates and try to fund a project. Really, that equation of you being the big difference maker, it really is. Radiating Hope is always willing to support ideas, support adventures, support ways to figure out how to think outside the box. And some of our team. And why we climb. So why do we do this? And it's, because it's not there, and we can get it there. We have a Radiating Hope Society that you can join to kind of keep track of events that we have coming up. And then in the end, I just want to conclude with that article that came out way back then, and the conclusion that they had way back then, which I think is really pertinent even still today. It says, "The time has come, therefore, to put off the end of circular arguments around types of equipment for different settings, the challenges in finding skilled human resources, and the contextual readiness of countries for radiotherapy service, and instead to embark on a decisive set of actions, time to take action and end the endless suffering, and time to climb that mountain." But thank you all for being here today, and let me take a few moments, and I look forward to getting to know you all better, and thanks.
Thank you, Brandon. Even I didn't know some of that stuff. Thank you so much. So we actually have a group photo before lunch. There's a lot more people in here than I thought there would be, which is fantastic. But we're going to probably need to make our way towards the front. I think we'll ask the people in the front row if you could please bring your chair up with you. We're probably going to need to have at least 2, maybe 3 rows. All right, guys. Can you guys hear me? So we're not going to fit in here, but there's a really nice staircase that you guys came down. We're going to just have to line up going up that way. So let's just, Tom Ladd is going to the staircase. If you guys can follow him, and we'll just take a photo over there. Thank you.